Welcome back to the show, everyone. I've got Dr. Rafi Ahmed with me, medical oncologist at Hoag Family Cancer Institute.
Nice to meet you.
That's a mouthful. Doctor, welcome to the show.
Thank you.
Appreciate you being here. You are specialized in urology.
Yeah, so I'm a medical oncologist at the Hoag Family Cancer Institute. My focus is urologic cancers that usually involves bladder, prostate, kidney, testicular. And I work with a group of oncologists as well as radiation oncologists and urologic oncologists who are the surgeons in our group as a team to treat patients starting with diagnosis all the way through their end of their treatment, whatever that may be. And yeah, that's my role as the medical aspect of it, prescribing medications, chemotherapies, focused targeted treatments at Hoag.
What made you want to specialize in that area of the body?
Yeah, so during my training, many years ago now, I did a lot of research in prostate cancer, circulating tumor cells, and the biology of prostate cancer. That sort of led to my interest and my desire to focus on this specific specialty.
Have you seen an increase over the years, or do you think it's steady now, or what are you seeing as far as the stats?
So it's a combination of both. I think that we have better screening, so that definitely is picking up more cancer. But the good news is with that screening, we are picking it up earlier, and that makes prostate cancer less deadly if it's picked up earlier. So when we look at the incidence of prostate cancer diagnosis, it has increased somewhat, but that's from better screening. But the actual mortality, which means people dying from prostate cancer, has decreased with early screening, early management, and preventing more complicated cases. So I think that what we've seen over the 10 to 15 years is an improvement in survival. Most patients who get prostate cancer live with prostate cancer, get treated with prostate cancer, and thankfully aren't succumbing to the disease. And the goal is to make that zero. So that's our focus here at Hoag Family Cancer Institute too, in our urologic program, about basically screening patients in our medical group, sending them to the urology team to advise them about their treatment options, evaluate them, and basically doing a personalized, focused treatment plan for each individual patient.
That sounds fantastic. Sounds like everyone's in very good hands, and the patients are in good hands. Is there anything specifically that you'd like our audience to know about your position there at the Hoag Center?
Yeah, so I think that the thing that makes us sort of different than a lot of institutes is we're always working as a team. From our initial primary care providers in the Hoag Medical Group, who always reach out to me or my colleagues in urology. There's that personalized care while still using the latest technologies and the latest research treatment options for our patients. Each patient is individual for us. Each patient is a personalized care plan for each, because it's not a one-size-fits-all for any person.
Right,
so we always focus on the patient and deliver very personalized care using the latest technology. When it comes to screening after initial evaluation with an elevated prostate-specific antigen, that's the most common screening test for prostate cancer. We then evaluate with further technologies, including MRIs of the prostate. So previously, what used to happen was anyone with a PSA that was elevated, there would be biopsies done, sometimes unnecessary. With more technologies as well as imaging options, we are really personalizing care. So those patients who don't need biopsies don't get them. Those who do get them, and then they're appropriately triaged, and intensification or de-intensification of care is based on genomic profiling, looking at the actual tumor, the patient's physical state, and delivering precise medical care for each patient that we see.
Wow, that sounds very intense. Sounds like you've got it all covered. So there's a lot of hospitals in the area.
Sure.
What do you think sets Hoag apart from Mission or Saddleback or any of the others that are offering the same type of care?
I think that one thing that sets us apart is our integrated care. We're all one team, and we consider each patient as our focus. So just today, if I had a question about a particular patient, I can pick up the phone and I know it'll be answered by my colleagues in either radiation oncology or urologic surgery. And it's the same way. They'll, middle of the night, if there's a question that comes up, they'll text me and I'm available. And that, I think, really brings the patient forward.
Yes.
And each patient is important to us. And working as a team, I think, we also have what we call nurse navigators that help our patients throughout this entire process, because obviously when you have a cancer diagnosis, it can be scary, it can be confusing, and I think our focus is not only the medical aspect of it, but treating each patient as a whole person and understanding the emotional aspects of dealing with cancer, as well as the physical aspects of it.
Yeah, because it is an overwhelming process, right? And so to be able to pick up the phone and actually speak with somebody really brings peace of mind.
Absolutely.
Right?
And I can also just say from my staff, from the nurses to even the schedulers, I am always impressed by the delivery of care from the moment someone gets that diagnosis and throughout the entire process at Hoag.
Right, right. And sort of lessens the fear a little bit, I would imagine. What innovative treatment options are there now for?
Yeah, so I think that from our surgical team, they are basically on front of the line in regards to treatment options, including, like I said, imaging-based biopsies using MRI and ultrasound that are focused and precise. In addition, when it comes to the surgical treatment options for certain cancers, most of them use robotics, which leads to faster recovery for all of our patients. From the radiation oncologist team, there's the ViewRay MRI-guided treatments, which basically gives the radiation oncologist, when they're treating these patients with radiation, real-time imaging to really focus on the cancer treatment precisely.
Wow.
From my aspect as a medical oncologist, we are really utilizing genomics and genetics and data about both the actual cancer as well as someone's genetic composition to either determine, do we need to escalate our treatment or can we decrease the intensity of treatment. So I think the ongoing focus is being very personalized. It's not a one-size-fit-all sort of treatment for every patient. It's learning about the patient, learning about their particular type of cancer, and delivering the most appropriate cutting-edge treatment for that patient.
Yeah, it sounds like the treatments are just evolving constantly.
Absolutely. Eventually my hope is to be out of a job. I think that's what most oncologists
that would be great.
That's what most oncologists want to do. We're not there yet, but even in the last 10 to 15 years, when I started treatment, there were very limited options, and now thankfully we just have ongoing options. In addition to that, Hoag does run a lot of clinical trials as well, focusing on GU cancers as well as prostate cancer and advanced prostate cancer. So we are always trying to move the pendulum forward and the ball forward in regards to cancer care treatment.
Now, back us up. Is there anything that men can do to be proactive or possibly preventative?
So yeah, I think the most important thing, like we have talked about earlier, is screening. In general, there is a little bit of flexibility, but most people say, discussion with your primary care doctor about a prostate-specific antigen test. PSA, or prostate-specific antigen, an enzyme that's released naturally by the prostate. Certain times when it's elevated, it can be indicative of cancer. Usually the screening recommendations say maybe at 45 to 50 years old. There are certain patients, especially who if they have a family history of prostate cancer or their African American background, or they're at higher genetic risk, we sometimes recommend earlier screening. That's usually that first step that gets us plugged in. Obviously, if there's any symptoms, although most commonly, most prostate cancer patients don't have symptoms, and we want them to not get to the point where it's so advanced to have symptoms.
Right,
so I think
right.
screening is a really important component of this, and accurately managing the results of that prostate-specific antigen test with imaging and determining, do you need biopsies, do you not need biopsies, is this a lower risk prostate cancer that may just be monitored versus needing treatment, is all a component of overall patient care.
And do you recommend the screenings to be annually, or how often?
It's a conversation, I think, and it varies based on risk factors. Like I mentioned to you, in patients who have a strong family history or African American background, we usually recommend an earlier screening, maybe at 45. After 50, most men should get screened, and it sort of depends on the PSA values and so forth about is that yearly or every 2 years. But that's a discussion with our doctors, and we're always available to inform the patient about their options.
Well, thank you for informing us about all the options. I appreciate you being here with me today.
Thank you for having me.
Thank you, Dr. Rafi Ahmed, for being with us today and all of that valuable information.